Today, my guests are Megan McGraw and Marianne Sevcik. They are both nurses, but what is unique about them is they are both former surveyors for the Joint Commission. Megan was with the Joint Commission for over 8 years and Marianne for 5 years. We are going to hear from them today on where a survey may intersect with the topic of a diversion program. Let's start with maybe some general. So in your roles with the Joint Commission, you would also perform surveys on behalf of CMS, correct?
Correct.
Yes.
Okay. Some may not quite understand that dynamic. Is an effective diversion prevention program addressed in the conditions of participation of CMS or in the accreditation standards of Joint Commission?
So really quickly, I would just say for the people in your audience that don't understand the relationship between the Joint Commission and CMS, most of the surveys that we did were called deemed surveys. And that is, you were getting a Joint Commission survey at the same time you were being assessed for the conditions of participation, which is CMS. So that's the relationship there with the Joint Commission. They're contracted with CMS in order to deliver that kind of a survey. So that's where this conditions of participation come in. In terms of something specific with the conditions of participation, for the most part, we find that the conditions of participation are pretty general. They don't get into specific programs such as an EHR, or electronic health record, that you have to use, or a specific diversion program. However, they do have stipulations surrounding what needs to be included in your drug diversion program, and they hold you to your policy. So I think it always begins with a strong policy, knowing that if you go above and beyond the standard in your policy, you will be held to your policy if it goes above and beyond the standard. So nothing specific. There are certainly some standards. I can let Megan fill in if she has comments as well.
Okay. And Joint Commission, then, do they have anything specific that kind of took care of CMS, right? Conditions of participation?
Yeah, well, and CMS does have 4225, does have some standards about drugs, but it's more, as Marianne said, generalized about keeping logs, keeping, a good inventory of how you receive your narcotics and things like that. Okay. Nothing specific about diversion, but obviously in that context, you could look at, well, if you're not keeping good logs, then you probably have a diversion issue. So they do have that. And where Joint Commission kind of references it is in leadership chapters, in pain chapters, and also in patient safety chapters. So that's where we can kind of link it to diversion programs is leadership monitoring, what it is that they should be doing in the way of diversion in that regard. So that's where Joint Commission may cross into some of those COPs that CMS has. So leadership, pain management, and then also, as I mentioned, patient safety.
Okay. I could see how pain management and patient safety, you just say you have to keep your patient safe, essentially, right? And so that includes everything.
Not just patients, though, Terry. Remember, we're surveying staff, too.
Oh,
remember,
okay.
Joint Commission, all of our standards are not just looking at patients, but also staff. Are you keeping your facility? Are you keeping your hospital safe for patients, staff, and families? So it's not just patients.
Excellent reminder. The leadership portion of it, do they mention diversion, or just that leadership needs to be aware and involved in everything related to safety and the big topics?
You want to take it, Marianne?
Sure. So again, it's relatively vague, I would say. There is a condition of participation that is as close to something specific as it's going to get, and that's Megan mentioned the 48-25. It's actually B. It's the letters and numbers behind it, so it's buried in there. But it says that the abuses and losses of controlled substances must be reported according to federal and state law. And the other conditions of participation do refer to federal and state law. So it's very important when the Joint Commission shows up that you understand your state law and that you understand that your surveyor, they just got off of an airplane. Half the time, they don't even know what state they're in. And so if there's something specific about your state in regard to diversion, it's your responsibility to know and articulate that well to your surveyor. So you may be educating your surveyor according to the state, the particular state that you're in. So in those moments, know your law and be able to articulate those well in regard to diversion.
Okay, perfect.
And I'll just add to that, there is no specific standard in leadership. So I want to make that clear about diversion. But what there are standards are is following policies and holding your staff accountable. So that is where that could possibly be something that Joint Commission could look at this program and look at that area of scoring potentially.
Yeah, holding your staff accountable. That would be a big one in this section. Yeah. When visiting a new facility, how do you assess effectiveness, or do you right off the bat assess effectiveness of a diversion mitigation program? Do you look at it specifically or in the context of everything else? And then you may see something that would cause you to look deeper.
You want me to take it, Mary Ann?
Go for it.
So I would say this, we go out on different survey types, right? The triennial is what everybody is familiar with, where we go around and survey to all of the standards and your deeming authority, which you do, or most hospitals do every 3 years. And I would say where we get into this is when we specifically trace the pharmacy service line. We'll go there, we will ask specific questions about how does pharmacy safely manage their medications, and diversion is typically when that is brought up. We used to have a breakout session that specifically talked about pharmacy, where your P&T committees and different types of patient safety programs would come together. But now that's kind of gone away, and the surveying process for that is now embedded in, how we trace through record reviews and all of the different areas that we go to. So typically when we're in the pharmacy, this is where we will ask those types of questions of your team, is why we're there. What types of things do you have in place for diversion? Oftentimes when we're tracing, even in medication rooms, we might ask the leadership there, hey, as a nurse leader, what do you do when you notice that, your overrides are a lot and whatnot? How do you work with the pharmacy and interface to deal with, some of the narcotics usages that you're seeing and things like that? So we do it in a variety of different ways, but I think the biggest way is in the pharmacy. And unless we're there for a specific cause, I would say, like we have what's called for cause surveys, we probably don't get into the details unless we need to. In other words, if there are things that we're seeing, maybe we see override rates that are crazy, a lot of overrides are going on, and we notice that in your data somehow, that might bring up the question of, what does your diversion program look like? So a lot of times I think we're triggered based on data that we see. So the data that you do on your medication error rates, your override rates, et cetera, things like that, your monitoring and tracking, that might allow us to have that conversation as well.
Those are great points, Megan. Yeah.
I say, any other cues, Mary Ann, that you think of that would cause you to, I'm gonna dig a little deeper?
Yeah. So the data, to Megan's point, that's exactly that. In policy, the documentation, if we see something off in policy as we're reading medication management policies. But I would say also that depending on the experience of your surveyor, they're very savvy at looking for things. And I know when I walk into a med room, as Megan mentioned before, we're looking at overall safety. We're looking at the environment. And this is just a story I'll tell. One time I walked into the OB department, was telling me, oh my goodness, we're finally able to pull out the epidural catheter here. We've all been in-serviced and we're competent. And so they're pulling out the epidural catheter. And I said, so who's wasting the fentanyl, in those cartridges? They said, oh, we've got this great plan. We're doing it. And they walked me into the med room, and there was a large plastic container they probably got at Walmart had 3/4 full of fentanyl filled cartridges. They were wasting it in the computer, but they weren't. It was just right there for everyone to see. Anybody who was anybody could have broken in there and gotten whatever they wanted. So again, you look at the environment, that's kind of an outstanding one. But things like when I'm out and about, even in outpatient areas, what do those rescue meds, emergency medications, how are those locked up? How are they handling procedural medications if they're doing some types of procedure? what is the safety in terms of storage, some of those kind of things. They call it love notes to staff. As a leader, I used to leave them all the time, but you can walk into an automated medication dispenser and it'll have on there, don't forget to check the discrepancies. Well, guess what I'm going to ask for? The last 6 months of your discrepancy report. So those are some other things that I think we just are all eyes and ears, and we're very good at asking questions like, tell me a little bit more about that. And before you know it, they're explaining those, which is why I would always say to tell staff nurses, if you get into a conversation that is over your head, call pharmacy. Let them speak for themselves. If you don't understand it fully, it's okay to phone a friend rather than have to have the pharmacy come in to unspeak your misspeak. Allow the appropriate person to have that conversation. So I would always recommend that a pharmacy person from leadership be able to round with those teams when possible. Certainly.
Yeah, that makes sense. And back to your fentanyl example, never talk more than answering the questions that you're asked. We're so excited. We can pull out the other. You're like, that didn't need to be mentioned. Not that you wouldn't have found it. And when you walk in the bedroom, but yeah, don't say anything that you're not asked about. Do surveyors get any specific training on diversion mitigation or specifically diversion software used in monitoring and those capabilities?
Yeah, I would say aware of their bio. Look at when you see the bio for the surveyor, it's wise for you to read that bio and understand what their background is. They could be a pharmacist. So just understand what their background is.
Okay. So their knowledge about those specific things would come from their background, not something that the Joint Commission trains them on.
We get training on a variety of different things. But about a specific software, I think is what your question was, Terry. No. And that's because, as Marianne referenced before, we go all over the place and everybody's using something different. So I think what our question is, what do you use, when you are trying to monitor diversion? Because that is something we do ask. And, some organizations don't have the funding to be able to do an electronic fancy thing. So if they're doing something through an auditing, we'll take that because we need to be able to, support that, rural area location that doesn't have the ability to look at a dynamic system. So I think in our surveying time, we get familiar with the different things and the different brands, but because we're there surveying your process and standards, we don't really have an overview of all of the different ones out there, just because I think that would be too difficult for Joint Commission, to do. What are the pros and cons of all these, different things? I think that's based on what the hospital wants to choose to use as their, diversion protocol or process. But I will say that, the interesting thing now is that there are actual pharmacists that are surveying pharmacy now. The Joint Commission has trained individuals that have that experience. And so, we really do try to make sure that the individuals that are getting to the pharmacy have, the background, the comfort level that they need when they're surveying. And I think, there aren't very many, but when we do have those team members on our team, you're going to find that they're going to the pharmacy as a certified compounding pharmacist or pharmacist. And so they're going to have that dialogue with you, obviously a little bit more detail than say a medical provider or a nurse who's going in there.
Right.
I think if there is really some upcoming things, the Joint Commission does a pretty good job of getting information out to us, just like anybody. Just-in-time training does occur. And we have annual conferences that we attend just like anybody else where we get these updates. So if there was something innovative or new coming around, I'm sure that we would get that opportunity.
Okay. So it sounds like from what you said, the software in particular would be, unless there's a background for it or they're a pharmacist, which maybe even then they may not be familiar with it. Software is an opportunity for the people at the site to educate on how it works, if that's necessary. Because there may be some false expectations, right, from the surveyor. Well, then why aren't you doing this, or look at this, or respond to this? It's like, no, that's not how it works. Yeah.
That's a great point, Terry, in that we always used to like to say as Joint Commission surveyors, just breathe and brag a little bit. If you're using a really phenomenal software program that you know is dotting your I's well and crossing your T's well, breathe and brag about it a little bit. Just remember that if you breathe and brag about something, to talk about maybe an improved practice, you saw data failing, and so you implemented this new software, and now the data is showing that you're at a better place. Bring that to your data session even. Breathe and brag about that. Just know that when you bring those kind of things up, then you're free to be surveyed on that. They're going to say, oh, well, show me
Right.
what you're talking about. So if you're going to bring it up, just be sure that you can articulate it well. But those are points really, if you've invested in software, you've invested in consultancy, and you really have that hardwired, be confident and breathe and brag about that, because that actually shows, that you've gone the extra mile for safety.
Right. And I think that's a good point, is that it's okay, and correct me if I'm wrong, it's okay to admit that you had some sort of gap and that you've identified it, and this is what you're doing to improve it and to work on it. You don't have to pretend that you've never had a gap or never had a problem or a finding within your own facility that was a problem. It's okay to admit that. Is that correct?
Absolutely. Not only okay, I think that it ensures us that you're being honest and open with us. We all know that nothing's perfect anywhere. Sometimes, it's the game of hide and seek rather than show and tell when we walk through the door. So it's actually encouraging when we just hear of the progress that hardworking safety quality interdisciplinary teams are making. That they saw a problem, they worked through it. Here's what they implemented. It's an ongoing process. They're still auditing it. We can actually walk away feeling very encouraged, and we may share those stories as we move along. We leave out the names and the places, but when we go to other organizations, if it's a leading practice, it's wonderful to be able to share that. Hey, at this other organization, they implemented XYZ, and it really seemed to be working for them. So, they were having the same issues.
Okay.
Yeah, totally agree.
Okay. One final question. Is there anything a facility can do if they feel their inspector does not have the knowledge to back up their finding and expectation? Not just, if you identify the knowledge isn't there and then you have the opportunity to educate them and all is well, that's one thing. But if either they didn't receive that education and they still hit you with a finding and really an expectation for action that really is not appropriate or overly laborious given, the situation, what can a facility do?
Go ahead, Megan.
Okay. Well, of course we knew this would be the big talk, and I did get a chance to look it up, Terry, but I'm sure that, even with CMS, and I've been on surveys with CMS in a deeming status, if you're not happy with a surveyor, you always have a way to complain. There's always a complaint process, or should be. Even with the Joint Commission, we have a way to complain. And I know CMS has that ability too, because I was on a survey where they had some issues and they had the right to complain about the CMS surveyors, not necessarily Joint Commission, but the CMS surveys that were there. I'm sure states have that same ability. Now, whether or not, I don't know what the follow-up is, but I do know that grievances are something that obviously CMS makes sure that all hospitals have a process, and so they have one too. And so, I would just encourage, your folks that if they want to talk to the lead, okay, normally there's a lead there, unless they're the lead, which it may be for pharmacy, they may be it. But always talk to the lead. So I'll go back and do that first. Talk to the lead, because there's normally a lead if it's a team. And I think that those issues should be reciprocated there, right? Or at least brought forward if you have a team. And just, I think, being honest about what your concerns are objectively, right? I think, when you are subjective, that's more difficult. But objectively, what are your issues? If you have a team, I think that's probably a good way to handle that if you have a lead. If you don't, and it ends up being a single, a person who's there, you do have that right to challenge with a grievance. I can't tell you what link to go to do that. but I'm pretty sure that everybody has that right to be able to say, hey, we found this. And again, I think most organizations want to make sure that they have qualified individuals working for them. And so again, how do they know if they don't get that feedback? So I think it's important that you do that and use that avenue if you truly feel like something was done inadequately after you made attempts.
Absolutely. I think the goal of every surveyor, we learn this from orientation and we live it every day, is that we want that report to be an accurate representation of what is really going on in your organization. So your team lead should have that in mind always. And if someone comes to them, as Megan said, objectively and says, we don't believe that this is an accurate representation of what's really going on here, there should be an audience to be able to voice that. There is a specific time that the Joint Commission team will set aside for a special issue resolution as needed. And the team leader can set that up where you can gather members of your expert team, multidisciplinary if need be, usually is, and you can meet with the team and just have a deeper discussion. There's also the ability to ask your team leader about contacting our standard interpretations group and getting on that call with them to make sure, if you really feel like that Joint Commission surveyor is just not seeing what you're seeing, the standard interpretations group will get on and you can have that conversation with someone in their organization that's meant to be in that leadership role. That's specifically what they do. They get on those calls and they support. So those are some avenues that you can take if you feel truly like your Joint Commission surveyor isn't seeing eye to eye. Definitely everything Megan said first, just come to that team lead and have a conversation. That may be the end of the day. That may be all you need, but there are ways that you can move forward with that.
Okay. Well, I've told you before, Marianne, you seem like a very reasonable surveyor, and not everybody is. And I've worked with Megan, so I know she's reasonable. Hopefully all of them are, but some of them seem like they're not.
Well, and the sad part is I don't know if we can say this here, but we're human beings. And we've been on the other side, right? Yeah. We didn't just become surveyors, right? We were on the other side of surveys. So most of us have that kind of mindset, but there are some, and we've worked with some, that really do have a bugaboo or an agenda or, whatever it is. But I think that ultimately, you have the right to a fair service. You have the right to fair and, discoverable items. And, I know, I was challenged one time about something that I might not have gotten correctly. And I said, all right, let's bring it to me, bring what you have, and let's sit down and look at it. You're right. Some may not be that reasonable, but I think people need to realize that they do have that opportunity. They should have that opportunity. And then if you're, I know it's a delicate thing because you're like, well, do we bring it up and then we get harder surveyed, right?
Yes.
And again, I think that that's something that you all will have to decide, right, in your assessment of how is survey going. But I still believe that there is a way that you can complain. You can make a complaint. There has to be, because I know, again, when I was there with the CMS team, we had, like Marianne had said, there was a special issue resolutions time. And what was given by that team lead was that you can call, you can voice this concern up through the CMS chain of command, whatever. I'm assuming state also has that ability. Again, it can be after the fact. It doesn't necessarily have to be during.
Okay.
But still, I think it's important that if you really do feel like you have somebody that is going to go around to another place and tell them, differently and incorrect information, that we all have the ability and need to be able to say, hey, this person might need some extra attention.
Yeah.
We need some one-on-one training. We're just letting you know.
Yeah. I think there's some psychological warfare going on with it too, right? It's like surveyors here, you don't argue. Yes, ma'am. Yes, sir. That's it. And then it creates a problem when you're like, you're wrong, sir.
Well, and I think you're right, Terry, and this is what this is about. So that's why I'm going to kind of chime in a little bit. It is about how you do it, right? And I think that's important. Is if you do come at it aggressively, or you're not right. We do have to look at how do we communicate it. And so again, I think like Marianne said, and myself, it's really in how you manage it. And if you go forward and say, hey, we'd just like to ask for more clarification about this issue, and do it in an objective way. I can think of 1% of the surveyors who might not be willing to look at that. But if you're coming with an objective, hey, this is the data, this is where we got our information from, the state, blah, blah, blah. I think that data is helpful. Or help me understand, this is where we got our information. Where did you get your information? If you can do it in a way that is non-threatening, I think that's always the best way. And most of us, I think, would try that. But it's when you get to those situations where I get it. It's beyond that. And what do you do? I still think there's probably a way that you can, complain if you really feel like you need to.
Okay. There's a formal avenue for every single Joint Commission survey that you have. There is an evaluation that is after the fact. We read those. So we get those in print, and they're anonymous. And they were a part of my evaluation, when they would read back those evaluations. So you are able to be objective in those. I think, again, to some of our previous points, that sometimes you feel like, oh, it's the Joint Commission, we don't want to push back too much, or we don't want a harder survey, or to get on their list of people who are difficult or whatever. But I always encourage people as a consultant now to fill out those evaluations in a truthful way. You can be just like an evaluation in an organization. Evaluations are important. It's feedback, and the Joint Commission does ask for that every time they ask for those evaluations. I think the other thing that has been brought up through Megan's comments, and also yours, Terry, is that there is a certain amount of psychology to every survey. We are human beings after all. And one of the simple but often missed tactics that you can use during survey, I teach my organizations this as a consultant. If somebody's not playing well in the sandbox with a particular surveyor, it could just be a personality clash. Put them with someone else. It could just be a simple matter of personalities not getting along. To Megan's point, hopefully that's going to be the rare occasion, the 1%. But occasionally that's going to happen. We're all human beings. We might be having a bad day. The organization person might be having a bad day. Be open to changing it up if you find that you're having a struggle with a particular surveyor.
Okay, great idea. Okay, this is great. Yeah, thank you for both of you taking the time to do this. It was very helpful, and I'm sure the listeners will get a lot out of it, because this is no small thing, right? I mean, we encounter surveyors on a regular basis, plus for cause occasionally, and it's going to happen. So thank you very much.
Awesome. Good to see you.
You too. Thank you, guys.